هذا الملتقى للاقتصاديين الصحيين منذ أن بدأت دراستي في هذا المجال منذ الثمانينات. فأنا معلش أنا هضطر إن أنا أتكلم باللغة الإنجليزية لأن معانا ضيف عزيز دكتور بي جارسون فهيكون معانا، فنحب إننا يكون معانا حتى في الحديث. As I said, it's my pleasure to welcome you today in the opening of the first conference of Arab Health Economic Forum. Actually, it's my pleasure also to be in this conference. As an old health economist, it was my dream to highlight the importance of this subject and to increase the number of health economists in the region to exchange ideas, draw policies, and such as efficient health programs. It was very difficult to convince doctors and health policymakers of the importance of economics in the health sector, as they thought this will turn health to be investment good rather than a basic right for all. It was also very difficult to convince economists with the importance of this subject if you talk about money and banking and finance and industrialization. And for them, health was a service. And they didn't want also to confront with the doctors. But gradually, and with the increase in world prices, population increase, and the trade-off between equity and efficiency, applying economic rules became a must in the health sector. Actually, health and economics are two sides of one coin. There is no economics if there is no health, and there is no health if there is no economics. And that was true when COVID was there. We saw the whole, all economies stopped because of the COVID. And this relationship, as I said, was very clear during COVID when nations felt the danger of a killing disease on the economy. So they increased the public spending and investment on the health sector to save the people and the economy as a whole. Actually, the trade-off was not between the economy and health, but between economy and disease. And this is why they felt the importance of increasing investment to the health sector. And health economics has become one of the most important newly emerging subjects. Health economics is an applied field of study that examines and finds systems-based solutions to make healthcare more equitable, accessible, and affordable for all. Health economists seek to understand the role that a broad range of stakeholders such as health providers, healthcare providers, patients, insurance companies, government agencies, corporations, and public organizations play in health care spendings. And it uses the tools of economics to such issues as the provision, finance, and financing of healthcare. Health economists are curious about what affects health outcomes, and they have several questions like how do we put a value on health, what factors influence health besides healthcare, what influences the supply and demand for healthcare, behavior of healthcare providers versus those seeking care, what are some alternative approaches to healthcare production and delivery. In examining the questions listed above, health economists address global issues as well, such as migration, displacement, climate change, trade, pandemics, vaccines access, disorders, obesity, and everything else. Health economics is important because it focuses on how the economic behavior of stakeholders and recipients affects the quality and cost of medical care. And as a response to the emerging national and international interest in health economics, the Arab Health Economic Forum, in cooperation with ISPOR, are organizing today and tomorrow the first Arab Health Economics Conference, Evolution of Health Economics in Arab Countries. The Arab Health Economics Platform is the first platform for health economists in the Arab world for networking, knowledge, exchange, capacity building, communication and advocacy among health economists, health policy makers, healthcare professionals, researchers, and development planners. I'm very proud to have many of the graduates of the program of the Masters in Health Economics at the Faculty of Economics, which I supervise, and Dr. Hala Asari is here. She was also a coordinator in that program, and now she is the Dean of the Faculty of Economics at New Gezia. So I'm very happy to see them here and to see them all holding very high positions. And that was the first joint program between two faculties in Egypt, in any university. And it was difficult to get an approval from the higher council of universities, but we got it now, and it is now approved by them. The main objective of this meeting is to encourage sharing knowledge and networking for health economics, but the conference, which is in 2 days, is addressing also important issues such as health technology assessment as a tool for innovative therapeutic evaluation, economic reform and equity, role of non-governmental organizations towards improving patient outcomes and equity, digital health across the world, localization and supply chain in health industry, improving patient access in different sectors on hospital level, health systems and big data. Least but not last, I want to thank Dr. Hala Said, I want to thank Dr. Khalid Dolafar, and I want to thank also Dr. Moiti. His session should be tomorrow, because of their support. When I told them the idea, they supported very much the idea, and I know that they found it very interesting. And the Minister of Health at that time, Dr. Khalid, he told me, where are the people, where are the graduates? I need them. They come from here. I mean, the graduates are working usually in private institutions or national or international, and I can't find them. And we will talk about further cooperation with the Ministry of Health, as we had this cooperation before between the Ministry of Health and the academia for having health economists more and more. I want also to thank the partners, Novartis and Eva Beatrice, for their support for the conference. And I want to make a special recognition to Dr. Shehani Sisi and her group. Dr. Shehani Sisi is the backbone for Arab Health Economic Forum, which started with a conference or a meeting with Dr. Mahmoud Wahidin on health and climate change. And she is also the co-founder of it and has put a lot of effort in the organization of this conference. And now I want to invite Dr. Mahmoud al-Mahdawi, President of ISPOR, to give a speech. He is with us, but online. Dr. Mahmoud. دكتورة جهاد لو سمحتي ممكن تكلميه لأن هو بيتكلم وتقولي له إن هو مش سامعينه، أو إننا ناخد دكتور حسام لحد ما نحل المشكلة. يعني دكتور حسام يبدأ. طبعا انتوا سامعين التوك وهو مندمج جدا فيه، انا بس خايفه يكون هو الميوتد ولا هو مش ميوتد. مش ميوتد. طيب ده عيب التكنولوجيا بقى. وكده خلص التوك بتاعنا هو خلص خلاص كلامه متهيألي.
أنا سامعكم كويس. دكتورة جيهان سامعيني دلوقتي؟
معلش دكتور، كلمته لحد ما تحلوا المشكله ديت، لان هو اوريدي، او كلميه، حاولي تكلميه تقولي له ان هو مش مسموع فيستنى يعني.
هي بس يعني اللابتوب نفسه هو بس المشكله يعني. ف just one second please.
ما هو اتكلم خلاص.
اعتقد اسمه دلوقتي نسمع.
Good morning to everyone, and unfortunately I could not be with you in the room today, so I'm joining virtually because of travel commitments. On behalf of ESPOR Egypt, I would like to welcome all the distinguished speakers, attendees, and guests from Egypt and all over the world, across the Middle East and across the world. Lou, it is always good to, I mean, I couldn't say here, I will see you in this case, but thanks for making the time and joining us in the meeting in Egypt today. We embarked on this journey almost 14 years ago. And what I mean by this journey is the implementation of HTA in Egypt. And despite multiple challenges, we never gave up or lost hope. Today, more than ever, healthcare systems face scarce resources, challenges in a post-COVID era, and this is where health technology assessment becomes a great tool to aid decision makers and policy advisors on how to best optimize and utilize the scarce resources that we have available. HTA provides a scientific means where decisions can be made based on numbers and facts, again, to optimize the allocation of resources. ISPOR, for those of you that don't know, stands for the International Society for the Pharmacoeconomics and Outcomes Research. It is a non-profit organization with chapters all over the world. And we're proud to have an ISPOR Egypt chapter which continues to grow year on year. ISPOR Egypt chapter has multiple activities, starting with raising awareness across different stakeholders in academia, in the industry, the Ministry of Health, and then capability building across different sectors as well, and then research and publications. After a number of years, I'm delighted to see knowledge and awareness is quickly spreading across Egypt and the region. Egypt has taken strong steps towards the implementation of HTA, and the establishment of pharmacoeconomics unit in the Ministry of Health is just one example. And we see the science is quickly spreading across the region as well, and that's why we have a number of attendees today and participants from across the Middle East. I would like to thank Dr. Jihan for inviting me to speak today. Briefly, I made the talk just much shorter because of the technical issues that we had, so in the interest of time, I made it quicker. But again, thanks for the invitation to speak as ISPOR President for Egypt chapter. We have a rich agenda for the next 2 days, so I'm very excited about learning more and listening to the different presentations and panel discussions that we have from our esteemed faculty that will be joining us and experts in the field. Thank you again for your time, and I'd like to pass it on to Dr. Jihan or Dr. Mariam, whoever is on site.
Thank you. Thank you, Dr. Mohammed. Thank you, Dr. Mohammed. And now we have Dr. Hussam Abdel Ghaffar. والمتحدث الرسمي للدكتور خالد عبد الغفار. He's going to talk about
good morning, everybody. First of all, I'd like to convey the apologies of Professor His Excellency Dr. Khaled Abdel Ghaffar, the Minister of Health and Population, that he cannot be with you today due to unexpected commitments. Happy all the time to be in the export. This is maybe my third or fourth time trying to participate in how to improve our health economics in Egypt. Health is highly precious, and at the same time it's very expensive. So keeping health is highly precious and very expensive. That's why health economics is crucial. People have the tendency to think that when you are talking about economic of health, that you need to increase the amount of money you are spending on health. This is true sometimes, or this is true all the time, but it's not the only affecting factor about health. Yeah, you need to increase the expenditure on health, but at the same time, you need to spend it in the right way and in the proper way, and that's where health economics come. It's very important to treat hypertension, but it's most valuable if you can spend more money in preventing hypertension than treating hypertension. It's important to treat cancer, but it's very important to spend more money in preventing cancer than treating cancers. People in Egypt have the tendency to go to hospitals whenever they are ill, no matter what the kind of illness they have. If you have diarrhea, you go to hospital. If you have heart attack, you go to hospital. If you have phallotetralogy, you go to hospital. If you have dehydration, you go to hospital. If you have headache, you go to hospital. This is how the overall Egyptian used to do. One of the most important things which the Ministry of Health and Population is goals and strategy in the next coming years is two things. Health is not only to treat ill patients. Health is about to improve the physical, mental, social, and spiritual health. So that's where we are aiming. We are aiming not only in treating people when they are ill, we are aiming to improve their life quality in the aspects of health, in their spiritual, mental, social, and physical. The second thing is you only need to go to hospital if you cannot be treated outside the hospital. If you can't be treated outside the hospital, there is no mean of going to the hospital, there is no value of going to the hospital. You will get more hazards going to the hospital if you are not indicated to go to the hospital. That's why there is a presidential initiative which is related to improve the primary healthcare service in Egypt. And we will start in 2023 with about 251 primary healthcare facilities where people can get their primary healthcare treatment and their referral, if they are indicated, from the primary healthcare. Our study showed that if you spend $1 for prevention, you will save like $6, which means you are talking about one Egyptian pound. At that time, it was equaling 24 Egyptian pound to save. Now we are talking about 31 Egyptian pound. So trying to prevent diseases from happening is the ultimate goal of the Ministry of Health and Population. It's not only because you save lives and you save money, it's also because you improve people's quality of life. So one of the most important things, our strategic goal in the next coming 2 years in the Ministry of Health, and to spend more money in prevention of disease, spend more money in the primary healthcare facilities, spend more money in knowing how to spend the budget allocated for the Ministry of Health and Population. And the fourth thing is the universal health coverage, which we are, and we have a very clear nose from the President, His Excellency Abdel Fattah Sisi, that we need to accelerate the application of the universal health coverage in all over Egypt. Thank you. Hoping to get very valuable information after the end of the conference so we can achieve our goals in the Ministry of Health and Population.
Thank you, Dr. Hussein. You mentioned quality of life, I think, quality of health. And I think with this word we should start, because to have quality of health and of life, that means that we will have healthy people, that means we will have more productivity, that will have the economy, that means we will have more money to spend on health services, and to spend on health services means we will have more wealthy, healthy people again, to have more of productivity and a better economy. So I think here is the link between economy and investment in health is clear. And this is why I said it's the two sides of one coin. And to hear now Professor Garrison, I invite my friend Dr. Saleh Sahati to chair this session and to have if you have first any question to Dr. Hussein, we have him here with us now, so it's this will be great. I mean, I always see the questions coming to the TV, so now Dr. Hussein is with us. If there is any question concerning the health sector now, before we, nothing at all. So before we invite Dr. Sameh, there are no questions. Then, yes? Okay, Dr. Sameh, the session is yours now.
Good morning. It gives me a great pleasure to chair this session and also introduce Professor Lou Garrison, who is Professor Emeritus in the Comparative Health Outcome Policy and Economics Institute, known as the Choice Institute of the School of Pharmacy at University of Washington since 2004. Professor Garrison is also a senior visiting fellow in the Office of Health Economics in London, United Kingdom, since 2016. He has been also the president of ISPOR. He has a distinguished career in economics with the pharmaceutical industry. He has published extensively on pharmacoeconomics and health technology assessment. He has a long CV, so I'll leave it to you to read about his distinguished career. And without further ado, I would like to invite Professor Garrison to the podium to start his presentation.
Thank you so much, Dr. Sameh. It's a real pleasure to meet this gentleman for the first time today. We find we have many friends in common, so that's very nice. It's really a real honor and pleasure to be invited to this first annual Hub meeting. Thanks to Professor Nassar and Professor Jihan for the invitation and for organizing this. It's all really about information and information sharing, which will be what I will be emphasizing, sort of the sharing of scientific information on how medicines work. So do I have slides and a controller? So, you know, I started in health economics almost 50 years ago, really. And I would imagine there were only 30 economists in the whole world, health economists in the world 50 years ago. And, you know, now at ISPOR, we have 20,000 people worldwide. And there are other organizations like HTA and others. So we sort of say that the division of labor in economics is limited by the extent of the market. Well, we can support people all around the world and their needs all around the world, and I think that's testimony to what's happening in Egypt, so it's great to see this interest. So I'm going to offer a perspective that's maybe a little different than is relevant to you all. It's what I'm calling it a one U.S. health economist perspective. It's a little different perspective. I'm focused more on financing innovation globally and access to medicines globally. And I'll talk about why that's important. I understand that, that medicines become generic, innovative medicines eventually become generic, and that's good value for money, and you want to spend your money there. But we also, as a global entity, are involved in financing the science around the world. So, some of the themes of the conference I think are very appropriate. One is health technology assessment as a tool. And so it's a technology, and the question is how to use it in different countries. There's not just one formula for how to do HTA. It's evolving. I mean, we're sharing information. We're kind of in a competition, but the countries in the MENA region are learning from each other's experiences and sharing information. And the other theme was, I'm sorry, the numbers are wrong, it should be 1, 2, 3, greater precision, that more medicines are being designed for smaller populations. And it's really testimony to the science, how the science has progressed. And that only happens because we're making broad investments all around the world. But it also means that if we're going to think about what's the value of in these very small populations, which are related to genetic mutations that affect the 8 billion people on Earth, how are we going to finance that? And I think we need a broader concept of economic value, and I will talk about that. And since Egypt, and I think it's very relevant to universal health coverage that's been discussed, and that has to do with the peace of mind you get from knowing you're protected. So here's some basic points to emphasize. One is science has what in economics we call public good properties. My use of the information doesn't keep you from using it. We can all use the scientific information. So it's a public good. So then we can also say it's a technology, so we can say what is efficient for the technology. Now, patent protected medicines, we have a system to incentivize the scientific progress. We provide intellectual property in terms of patents, right? So the question becomes, what is the optimal rate of innovation globally for everyone, for all 8 billion people on Earth? How do we support that innovation? And then the other key fact is, once we've invented these medicines, the marginal cost of making them is very low in real terms. So there's a big upfront cost, and the marginal cost is low, so it's logical that we could provide access to low-cost things, but we'll have to charge different amounts in different countries, differential pricing. So I want to talk a little bit about these topics, financing them, delays in access, the HTA as a technology. What do we mean by value in economics, and what do we think when we talk about innovation, what are we talking about? And then finally, improving global access. When I speak to audiences around the world, people don't have a good concept of how rare it is to produce good medicines. And you can see that, at least from the US point of view, we're only producing about 40 new medicines a year, innovative medicines. Now what has happened is, some of these are what are called Me Too's, but others are actually first in class. We still have over half of them are the first in the class. Over half of them are for rare or orphan diseases now, and the regulators are trying to speed up access. But the basic proposition is the same. These are high risk, high reward. 9 out of 10 drugs fail in the pipeline. I worked in the pharmaceutical industry over 20 years ago, and most of the products I worked on failed. But the big successes finance the industry. And so there are very few, and it's constantly changing because medicines go off patent. Now this is a slide comparing prices, and I used this in a talk in Mexico recently. And basically, you can see that these are US prices at the top relative to the rest of the world, and the US prices are much higher than the rest of the world. And you can see down here, the lower is 2 to 3 times higher than the Canadian prices. And you can't see this very well, but if you look at this, the relationship between ability to pay and what different countries pay is not very tight. Okay, so some countries are paying a lot less than they can contribute, where in this case, Mexico has high prices relative to their ability to pay. So the system is broken from that point of view, that we're not spreading the financing of the R&D appropriately. The other thing you see, and this comes from the European Federation of Pharmaceutical Manufacturers, is there are delays to access. So, logically, many of you have a pharmacy background, and what do the regulatory bodies like the FDA and the EMA do? They make an assessment if the benefits, the health benefits outweigh the risks, and the product can be put on the market. At least they don't look at price to start with. They look at that benefit risk. And so you could say, well, these folks have said that we have this entity which doesn't cost that much to make. The benefits outweigh the risks. So you say, well, why shouldn't everyone have access to it? But you see that there are delays in access. So, the European average for all products, and this is a study, is over 500 days after it's on the market. And you can see this is a graph from all the products from 2017 to 2020. And there were 160 products approved in Europe in that period. Only Germany had 147 that they have access to during that period. You go all the way down here, Turkey only had access to 24 of the 160 that were approved. So that is a delay, and that means that people are losing quality of life and length of life during that period. And you can look at it this way. So in Germany, the average time to access is 133 days, but in Poland, it's 800 days. So during that period, people who could have benefited aren't getting the medicines. Now, some of the medicines are more critical than others. Some are truly life-saving, many are not. They're life-improving. But the question is, why should we have that delay? Now, HTA is part of the story, and the question is, is it a barrier or does it facilitate access? Now, we've been defining HTA for 30 years, and the ISPOR, working with HTAI, has produced what I think is a very good definition that it's a multidisciplinary process that uses explicit methods to determine the value, and I'll talk about what value means, at least to an economist, over the whole product life cycle. So a drug like Lipitor, you know, for atorvastatin for lowering cholesterol, was launched in 1998 in the US. It went off patent in 2011. It's still the most prescribed generic medicine. So people are getting the benefits over that very long period, over 30, you know, nearly 30 years. Now, we want to inform decision making to promote an equitable, efficient, and high quality healthcare system. Now, what we see around the world is what I would say is a continuum. On the left-hand side, we have those systems that are very quantitative, and they look at this concept of the quality adjusted life here. That the idea is to promote health gain in length of life and quality of life. Now, that's the UK is the prime example of that through NICE in the US. The US has a system that looks at the quality, but we don't really use it in the government decision making. In the middle, we have countries like Australia and France that look at the data differently, okay, look at qualities. On the right, we have Germany, which really focuses on the clinical data and doesn't actually explicitly compute the quality. So there's a range of ways to do this, and it's open to question what is the best way in any given country. But I want to emphasize about the transferability, what we call transferability. And basically what this says is that biology travels across borders. So, you know, the products that work in America will work in many people in Egypt and vice versa. So finding that information, those studies, that can be used. Each country does not have to redo all of that analysis. It's more efficient to say, well, we know it works, and that's transferability. On the other hand, what's efficient in the United States is not necessarily what's efficient in Egypt. So so generalizability has to do with the final decision. So different countries have different ability to pay, so they're not going to be able to finance the same things. But you're probably aware that they're talking about harmonizing HTA in Europe with sharing the clinical data across countries. You don't need to redo all that. We don't need to, there's not an EMA in every country. That's an example of that. So you want to do that. You want to have a joint clinical assessment, but the decision about the health, what goes in the health insurance benefit package will vary by country. So we're talking here about, I say, lower income countries. I mean lower than the highest countries. So there are some obvious challenges that lower income countries face in terms of limited resources, experience, and available expertise. So efficient HTA needs to use that information from other countries. So what is value, at least what is value to an economist? It's what someone is actually willing to pay or give up, what they have to give up in order to get something. That's what we would call economic value. One of the things is value varies across people. People have different valuations. Health systems have different valuations. And my valuation of a given product would change over time. It's difficult to measure in healthcare because people have insurance. So they're not actually paying out of their own pocket. We're making a centralized decision. And finally, at least from a US health economist perspective, the question I would like to ask is, if I said to you when you're 20 years old, maybe you'll need a heart transplant sometime in your life. Okay, so you're in a system, you want to finance that. How much would you be willing to pay per year in your insurance premium in the event that you need a heart transplant in your life sometime? And I would say that number is so small compared to what you're going to pay over a lifetime that we can't really answer the question. So the whole mechanism we use of the quality adjusted life here and the threshold of willingness to pay is a workaround to try to put relative valuation on things. Now, the U.S. is also facing a resource constraints, so and the people are concerned about rising drug prices in the U.S. And so at ISPOR, from about 2014 to 2016, a number of what were called value frameworks came out by different organizations. I won't go through each one. And they tried, and so ISPOR was confusing people, and people were saying, well, what are all these value frameworks? How can we make sense of these? The oncologists have a framework, the cardiologists have a framework, ISPOR has a framework. So we wrote a report to sort this out, and I think a key factor here is to think about this as this chain or cascade that you have at the top level. The first question, do we include it in the health plan? And at what price? That's the inclusion in the health benefit. And that's mostly what cost effectiveness analysis and ISPOR is about. Do we include it in the health benefit package? Once it's in the health benefit package, you have to manage it. You have to say, well, who can get it? What is the role of the provider? And we call this benefit management or access and utilization. And then once you're through that, then you're down at what we call the shared decision-making position. And this is really what the American Society of Oncology and the European Society were worried about. When you're the patient sitting with the doctor, you want the doctor to be your good advisor and not be worried about all the society's problems. You want to be said, given my situation, what is the medicine for me? That's shared decision making. Now the question I'm usually worried about with cost effectiveness is this: what should we pay to reward the innovation? And that's at the top level. So we eventually developed what's come to be called the ISPOR value flower. And most of these analyses, the quality up here, the quality adjusted life year and net cost, that's the cost effectiveness ratio. And that's what these systems look at. We also worry about productivity in the system. But what we came to realize is there are a lot of other things here that have to do with uncertainty. Uncertainty is a very important part of medicine. That's why we have the regulator to certify the quality. That's why we have requirements for training and so on. So uncertainty is important. And so we started to look at uncertainty and insurance value, and we started to look at other concepts related to uncertainty: insurance value, value of hope, real option value, equity, and scientific spillovers. Let me just talk about one of these. I think the most important is really insurance value. And I would take you back to the thought experiment. In November of 2019, before COVID came, if I said, well, what's your quality of life on a day in November where 0 is death and 1 is perfect health? I would like to think it would be pretty high, 0.99, 0.98. Okay, but come February and you've learned that COVID is out there and we have projections that tens of millions of people might die from COVID, and we're being told we don't have any vaccine we can do, okay? So if you're rational, I would say your quality of life should fall. You should say, I'm worse off than I was in November. And that affects that's just on the idea that nothing can be done, and that affects everybody on Earth. 8 billion people are affected by it. So it's the fact that we don't have an mRNA vaccine at that point, and it's just a gleam in someone's eye, it becomes very valuable. But come September, when we've had the trials and we've learned, we've been able to produce vaccines and they're very effective, your utility level should go up. We call that health risk protection. Now, what I would say is that's exactly the same thing that applies to having universal health coverage. The big problem of not having health coverage is that you live in fear of losing all your money. It's a fear. It's kind of a fear factor. Universal health coverage gives you that peace of mind. And that's not just in the quality, it's a mental thing, okay? So we're saying if we're going to reward innovation, we need to pay for these reductions in uncertainty. And I think, again, just this insurance value, these are related down here. And so we call that universal health coverage provides that. So we promoted that. Now, I'm saying we need to go beyond the quality, but I will point out that we have 12,000 studies that have used the cost per quality because people think it's useful. It's useful to say, okay, diabetes gives me this much life years. A cancer drug gives me. I want the reward to vary by the life expectancy gain. I want to send a signal that we value life and quality of life. So these studies are useful, but they're not the end of the story. So we had at the ISPOR Vienna conference in November. I had a panel with people from Poland, Kazakhstan, and Hungary. We listed all the problems in creating efficient HTA. You need capacity building, you need budget, and so on and so on. I won't go through all these, but there are a lot of barriers to efficient HTA. And I use economists' favorite word is efficient. We're more worried about efficient when production processes can be efficient. Equity is a much tougher concept than efficiency in a way, because the fundamental problem is this. I can talk about equity of outcomes, or I can talk about equity of opportunity and process, right? Everybody can have the same opportunity, I'll get different outcomes. But if I don't like the outcomes, I've got a problem. I can't have both. I may not have both. So equity is a challenge itself. Now, the problem I'm concerned about is this global access problem. Given that the marginal cost of making these is low, and we saw this in HIV, for example, when HIV medicines were being developed in the US, the prices were $20,000 to $30,000 a year. Okay. Once we allowed generic manufacturing in India, they could make those treatments for $125 a year. So you're saying, okay, we had to spend a lot of money, we had to finance it by paying $20,000 a year for this, but then we get them for $125, and we can offer them in Africa for $125 a year. But even in South Africa, which had 40% of the people with HIV, they could not afford $125 a year. So the wealthier countries had to subsidize it, but we did. So we can do that. We can get these down. Now, the question is, well, why is there that delay? Why does it take so long for Turkey to get access versus Germany? Part of it may be that the companies are just saying, look, my money is being made in the United States and Europe. I'm not in a hurry to go to these other places. That could be part of the problem. It could be that the demand side, the government says I have a limited budget, so I'm not in a hurry to bring this in. But you know what that means? People are dying just like in HIV because they didn't have access. And then there's these issues of extra. Everybody looks at the other person, and the American says, well, if the Canadians can pay so much less than us, why can't we get that price? And we don't do a good job of explaining that we have this system where the rich people should pay more because they benefit more, they value it more, they can contribute more, but at the same time, if everybody puts some money in, we'll be better off. So, but we should recognize that we should have differential pricing. Individual countries, what I'm recommending, they should monitor FDA, EMA approvals. And then say in Kazakhstan, what that should say is, look, the EMA said this is good, the FDA said this is good, and it produces large health gain. I don't want to wait 7 years to get access. I want to call the companies in right now and say, we want to negotiate. Kind of what they do in China now. They run a tendering system, they say we're going to have a negotiation and speed that up. So at the same time, the prices should be related to the value in the local system. So just a few final takeaways. So, a lot of the use of this information in the system depends on the incentives to use the information. Economics is really about incentives, not so much costs, right? But at the same time, all systems are subject to political influence. And so you have to you have to design the system so that it's protected from too much political influence. Stakeholder engagement and what's called a deliberative process is important in all of these systems. Studies have shown that the LMICs have limited capabilities for what they call an evidence-informed deliberative process. I'm arguing that, and I'm trying to start a special interest group to identify where are the big health gains, and let's get access to them in countries like Egypt as fast as possible. Cost per quality is useful, but we need to think about severity of illness and valuation. And I just end by saying this is a global enterprise. We have 8 billion people on Earth involved in this. And we want to use, to get a value-based price and incentivize appropriate innovation globally, we need to do a better job of developing this system of value-based pricing and differential pricing. So Dr. Samang, thank you so much for the introduction, and thanks again for folks for I hope this was useful, and we'll have a discussion. Thank you.
Well, thank you very much, Professor Garrison. It's very intriguing and very interesting presentation. I think I find it very difficult to summarize what Professor Garrison just, presented. I'll try my best to maybe share with you at least my understanding of the key highlights. He presented, the importance of research and development in promoting innovation, but also he mentioned that the price of R&D, of research and development, is not fairly distributed across countries. He also explained the delays in approval of some of these innovative medications or medicines. And then he mentioned that health technology assessment, the main goal of health technology assessment is to promote value. So it has a value proposition. He then presented different health technology assessment models. Now I cannot read my handwriting. This is typical for physicians. Anyway, and that health technology assessment harmonization is important, and the trade-off or the balancing act between transferability and generalizability. He also presented some value frameworks and the decision cascade, including the shared clinical decision making. We also presented the uncertainty regarding future health risks and the importance of universal health coverage as a way of protecting against those future risks. And he also presented, and I find this very interesting, 10 challenges that are facing the development of health technology assessment in low and middle income countries. And finally, he presented the global access puzzle. Why there is a delay in getting those medicines and innovations in low and middle income countries, and he has identified, supply side as well as demand side, as well as market dynamics that prevent the access to these medications. And finally, he has made some recommendations in order to facilitate the introduction and the proliferation of these innovations in low and middle income countries. So again, Dr. Garrison, thank you very much for a very, I would say, very rich presentation. Now I'll open the floor for questions. Going once. Please. Do we have a roaming microphone for the participants to ask their questions or make comments?
Good morning, everybody. My name is Ahmed Jadair. It's good to see you again, Prof. Garrison. We met a few years ago in Riyadh during the health economics course with the University of Washington, and I really thank you for the nice presentation. It's a common question that I get asked all the time when talking about, health technology assessment, value, and okay, sure. So, very common question. I'm sure that you got also asked this question before. It's related to the prioritization when it comes to decision makers when they are presented with the HTA assessment or appraisal, when they are presented with the data from clinical trials in terms of the safety and efficacy, and the medication has been already registered by their regulator, so they assure the quality of the medication. And then they always have a limited budget when it comes to spending on health technologies. So the issue with the decision makers is that they need to prioritize their spendings on multiple patient population. So for example, if I'm going to be using a very expensive gene therapy for a small population that is going to cost me the same as spending a medication, for example, for chronic disease, say diabetes or hypertension, that has been shown to reduce morbidity and mortality for almost the whole population under my coverage. To what extent should we consider prioritization schemes in terms of prioritizing spending on health technologies, including medications, as decision makers?
I think so. I hope, nice to see you again. Okay. I think I have a picture of us together giving someone a certificate, right? Is that right? It was nice. So, if I understand the question, forgive me, but it's about prioritization, and the problem is, I think that you're saying, look, I have to serve a big population, and it's much more efficient to use generics to cover chronic health problems than to spend on a few people who have a rare mutation in a cell and gene therapy. Now, I guess my argument is we have better differential pricing for small molecules and for biologics. We have biosimilars, but this market for cell and gene therapy globally is not well developed in terms of differential pricing. And honestly, I don't know, for example, when I said that we were selling HIV medicines for $20,000 to $30,000 a year in the United States, but they only cost, they only cost $125 to make a year, okay, to essentially the Indian price. So that's the difference in a small molecule. Okay, what I don't know is for a gene therapy, it's more costly. Some of the gene therapies sell for over $2 million in the US, the starting cost, right? But that's over a lifetime, right? But I know it doesn't cost $2 million to make it. What is it? And a lower income country should be able to get a lower price for selling gene therapy than the US. But you know, how do you work that out? Well, you work it out with confidential discounts across countries and individual negotiations. So I would think the sellers would be willing, just like they do for other products, to give different prices in different countries based on ability to pay through confidential discount agreements. That's the only way I can see to do it. But they're not. But if the money's not there, they're not in a hurry to go to Kazakhstan to sell a rare gene therapy. There's not that much money in it. But at the same time, people all over the world suffer from these diseases, from these mutations, and so we do need to have differential pricing. But I would say, but I understand if you can't get if the differential pricing system doesn't work, you know, a person in a low-income country has a hard choice. They can't. Doesn't make economic sense to spend the money on those people. But it's really a failure of having a global system to finance and distribute the medicines. Does that make sense?
Absolutely. And that actually brings a question to my mind. What role do you think the international development agencies can play in facilitating this process of, so if you are invited to a meeting between those development agencies and the pharmaceutical industry that are responsible for those expensive drugs, what strategies would you propose to make it a win-win?
Well, one thing about economics, we sort of say the market sort of solves problems, and the market has not solved this problem, okay, is what you're telling. So this gentleman is the expert on international organizations, not me, okay? But you know, the thing that you can answer the puzzle for me, okay, the problem is we have a hard time explaining to the general citizen why Americans should pay more for something than people in Canada. And, you know, so we don't explain that medicines are different than automobiles and corn and wheat. It's a different kind of market. We have intellectual property, and we have to incentivize R&D. Now, for me, the logical thing, the World Trade Organization should have said, okay, we're economists. We understand that this market is different than other markets, and we have to run a differential pricing scheme. So you can imagine running a differential pricing scheme. Now, the FBA in Europe has promoted something called equity-based pricing. And what they're saying is, look, and they mean, the income levels in Europe vary a lot, and the countries with lower income should face lower prices. It's equitable for them to have lower prices. And so they've tried to say, we're going to agree to, we're going to break the link between external reference pricing, and we're going to have the high-income countries lumped together and the low-income countries, and they can't reference each other because that destroys your ability to do differential pricing. So my answer would be, I would love to see the World Trade Organization step in there and say, this is a different market. Now, that's such an obvious point, there must be a good reason that that hasn't happened that I don't understand, but that's your job.
Well, I was hoping to get some help from you, because you know the pharmaceutical industry is really good at sort of segmenting the market and focusing on high-income markets, of course, because of the profit margins are very high there. And I think Egypt has done a good job in negotiating prices for its hepatitis C disease, and was able to negotiate a good price for treatment. Okay, are there any other questions? Are we good on time? Oh, all right, okay, all right. Okay, if there are no other questions, let me again, please join me once again to thank Professor Garrison for his very interesting presentation. And again, thank you very much, Garrison.
First, I would like to thank you all for being here today. Thanks to everyone who are actually eager to learn, think, discuss, and share different policies. And special thanks to the experts who actually came from different countries, different backgrounds, different authorities. So I will call it in Arabic, نورت مصر. So first I would like to have the panelists on the stage, please. Professor Ayman Khatib, Vice President of the Egyptian Drug Authority. Professor Hisham State, Vice President of the Unified Procurement Authority. Professor Hussam Abdel Ghaffar, Secretary General for the Supreme Council Universities. Dr. Mohammed Al-Aad, General Manager for Secondary and Tertiary Care, Egyptian Health Authority. Professor May Farid, Chief Executive Officer for Universal Health Insurance Authority. Professor Ahmed HTA, Assistant Deputy Minister of Therapeutic Affairs from Saudi Arabia. Please welcome all the panelists. Moving from ideas to actions. So actually I believe that improving access to innovation is very important. I think that without innovation there will be no generics, no sustainability for the healthcare system. I think that every healthcare system is unique. Each healthcare system has a pros and cons. So I think that we have to find different solutions for different uncertainties that actually we have in a healthcare system. So I believe that sharing policies and discussions is the first step or for any healthcare reform. So I will start with Professor Ayman Khatib. Would like to ask you about could we oblige the pharma companies to collect data before or during the registration process?
أولاً بسم الله الرحمن الرحيم وبشكر السادة القائمين على تنظيم هذا الحفل الكريم وتشريفهم ليا بالحضور والمشاركة فيه، اللي أنا دايماً بشارك معاهم في كل إيفنت بتحصل. ورحب طبعاً بالسادة الكرام أعضاء المنصة الكريمة. في الحقيقة احنا عندنا الترم بتاع الانوفيشن. طبعا ده مع انشاء هيئه الدواء المصريه كان متاخد في الاعتبار فكره الانوفيشن ديت والادويه المبتكره بالتحديد، فبذلك في الهيكل التنظيمي بتاعها انشئت اداره عامه خاصه بالانوفيشن برودكتس. وطبعا احنا مع انشاء الهيئه والانوفيشن برودكتس والحاجات اللي احنا بنحب اللي هي تبقى اكسسبل للمريض المصري، مع انشاء هذه الاداره العامه ربنا كرمنا كمان بقانون تنظيم الابحاث الاكلينيكيه واصدار اللائحه التنفيذيه بتاعته. فبالتالي احنا عايزين نتفق على كلمه الانوفيشن. لو انا بتكلم بالنسبه لي في مصر، الانوفيشن برودكتس بالنسبه لي هتبقى نيو كيميكال انتيتي او مولكيول، يعتبر مولكيول جديد. فبالتالي الخطوات اللي احنا المفروض بنطلبها في حاجه زي كده هتبقى في ساينتفك كوميتي تبقى تعمل ابروفال للفكره اللي هي عاده طالما انوفيتيف برودكت هيبتدي يتسجل في مصر، فبالتالي لازم لا مفر ان احنا نستفيد من قانون تنظيم الابحاث الاكلينيكيه واللائحه التنفيذيه بتاعته. فبالتالي لازم يكون عندنا بري كلينيكال ستاديز تبقى ابروفد، ثم نمشي بعد الابروفال للكلينيكال ستاديز بالفيزز المختلفه نهايه بفيز 3. الحقيقه القانون واللائحه التنفيذيه بتاعته خلت السلطه الوحيده اللي تقدر تخلي الكلينيكال ستادي تبتدي اللي هي هيئه الدواء المصريه. هي الجهه الوحيده المنوطه بالسماح بالدخول في فيز 1 لان هي الجهه الوحيده اللي بتوافق على البري كلينيكال ستادز. ده كونسيبت بتاع الانوفيشن بصفه عامه. انما لو احنا ما بنبصش للانوفيتيف برودكت اللي هو نيو كيميكال انتيتي اللي هي تبقى بالنسبه لنا في مصر هتاخد وقت لحد ما تحصل، هي مش صعبه، هي صعبه ولكن ليست مستحيله. بنفكر بقى في الانوفيشن بشكل اخر اللي هو ممكن يكون الانوفيشن ده في شكل ريبيربوزنج لدواء، يعني بحط الجرعه لاستخدام جديد، او ان مثلا بتبقى الفارماسيوتيكال دوزج فورم بتتغير. فطبعا لو انا بتكلم على الكاتيجوري الثانيه اللي هي تبان اسهل، المفروض ان ده دواء كان موجود في السوق، الناس بتتعامل معاه، اثبتت التجارب بتاعته ان هو سيف وافكتيف بالنسبه للاستخدام الاساسي بتاعه. احنا بس هنبص على الاستخدام الاخر. طبعا احنا كلنا عارفين الانوفيشن بتبقى قصادها برايس. ففكره البرايسنج بتاع الانوفيتيف برودكت دي تبقى عائق كبير بالنسبه لوجود الدواء اللي هو المفروض يبقى اكسسبل للمريض المصري. فطبعا في طرق كتيره لحساب الكوست بتاعه علشان في الاخر نصعد بسعر فير ونقدر نديه للمريض المصري، اللي هي عاده بتنصب في جزء اللي هو بتاع الفاليو بيزد برايسنج. الشركات المفروض وهي داخله في مرحله التسجيل بتجيب كل الدوكيومنتس اللي بتثبت اي كليم هي بتفترضه تحطه قدام ايد هيئه الدواء المصريه، فبتساعد. فمفيش اي حاجه يعني انا مش فاهم الحقيقه اوبليك ديت معناها ايه اللي انا ممكن اضيفه لان خطوات التسجيل بتبقى خطوات معروفه. فلو حضرتك تقصدي الاوبليجيشن دي تبقى في جزئيه معينه يا ريت توضحها لي، لان الملعب مفتوح ليها تحط اللي هي عايزاه.
لكن انا مينلي بتكلم على فكره ان مثلا لو الدواء ده اتسعر بسعر غالي قوي فهو ستيل في uncertainty في الايفيدنس بتاعته. فهل ممكن ان هو يعني نقول للشركات ان هي لازم تكولكت داتا، لازم يكون في يعني kind of data should be collected beside the registration process. I think انا فاكره حاجه زي كده حصل في ادويه هيباتيتس سي.
يعني انا عايز اقول يمكن حضرتك تقصدي بقى ان البرفورمانس بيزد برايسنج ولا حاجه ثانيه غير
يس يعني ده اكزامبل.
لان هو الطبيعي الشركه لما بتقدم والسعر بيقبل بيعتمد على داتا الشركه بتقدمها وبتدرس في الهيئه عندنا، وعلى حسب الكلينيكال ترايلز في الاساس بتبقى فاليو بيزد، ولكن هي بتفترض حاجه فبيسعر على اساسها. لو ان الداتا اللي من خلال الشغل والكلينيكال سيتويشنز اللي هو ابتدى يستخدم بالفعل، فممكن جدا الشركه بتقدم ما يثبت ان الدواء ده البينيفيتس بتاعته تستحق السعر وممكن السعر يزيد. فلو حضرتك تقصد الكلام ده ان الشركات تقدمه في الاول طبعا يعني.
Thank you. Professor Hisham Said, what are the novel mechanisms of action, or as we said, what are the novel mechanisms that could be taken to ensure a fair price? Please be free to talk in Arabic or in English. I will conclude at the end.
You are asking for fair prices?
Yes, fair pricing.
Okay. The word fair is very controversial.
Very debatable.
Fair to who? Because the main problem of health economics is solving the scarcity of resources. So we are in a middle to low income country. So the health resources are already scarce. And according to the latest development in the financial market, the pressure on the currency is increasing. So the pressure on the resources is increasing. So I think UBA now is doing the most effort to get the fair prices to both win-win situation between the producer and the country. UBA is responsible for all the governmental pharmaceutical purchasing for the governmental sector. So we are manipulating or managing the whole budget, and we are trying to cover all the needs for the governmental sector, covering from 60 to 70% of the population in the health insurance, for example. and 100% of population in special sectors like infants, like vaccinations, obligatory vaccination, and so on. And even all the residential initiatives are covered 100%. So when we are negotiating prices to make it fair for us and for the producer, we are using some of bargaining powers that we have. And for the producer, he thinks that it is a win-win situation because against volume or against new entry for his product in the market, he's getting a lot of discounts. That is confidential, of course, between us and him. In return for new entry and putting a footprint in the Egyptian market, which is huge. The next 10 years, up to 2030, the Egyptian health expenditure, percentage-wise, year over year, will not be replicated in the next 10 years because now, year after year, we are increasing from 15 to 20% health expenditure. So this value of growth will not be replicated. It's not there in any other neighboring market. So the market is very juicy for the companies, and it is appealing for new products. If you are talking about innovations, the innovative products, we have got a very good deal that most of the originators are now getting UPA prices almost like the biosimilars, or almost like the generics, just to be there in the new protocols. So this is the first step to encourage them to get fair prices for both of us, if this is a fair price.
Okay, thank you. I move to Professor Hussam. Is there any current or future policy or maybe regulatory framework that could improve innovation access?
Thank you for the question. Actually, there is not only policies or strategies, there are action plans. So there is an action plan with a very clear timetables and very clear budget allocation for the new innovation and drugs and the consumables and the health sector. And let me remind you and my dearest colleagues and the guests and the audience about the COVID pandemic, and the budget was allocated for the first Egyptian COVID vaccine, COVIVAX, and there is 2 scientific groups already working with that. So, if your question, if we have strategies, I'm telling you, yes, we have planned not only strategies, and with allocated budget and a very clear agenda where we are headed.
Thank you. I'll move to Professor Ahmed El-Judai. What are the novel key points that already taken from the Ministry of Health or the Saudi Ministry of Health to improve innovation access?
Okay, I'd like to thank you first of all, Dr. Jihan, for moderating this session. I would like to also thank ISPOR chapter in Egypt for arranging such a wonderful meeting. So basically, in the Ministry of Health, the Saudi Ministry of Health, we worked on multiple aspects related to improving access to innovative medications, including, but not limited to, working with the Saudi HTA to accelerate registration of innovative medications. Now we have an initiative called registration of breakthrough medications, which takes a totally separate path for registering medications, things that have not been registered anywhere else, and they are very promising, either as a new class of medication or a class of medication that has just been introduced in the market, but this is another member of the class, possibly for a different indication. And this is very common in immunology and oncology and others. Also, it includes the registration of several cell and gene therapy. So with this new pathway, we are proposing a rollout approach registration where they can submit the data as it becomes ready, so that the Saudi HTA will be the first regulatory body in the world to register that molecule. That's what we call a breakthrough, and it's very new to us now. We already have accelerated or abridged pathway for registering other medications that have been already registered by another regulatory body. So that's one of the initiatives that we worked on. The other thing is we started our Health Technology Assessment Center last year, and it's going to be fully functional hopefully by this year. Our Health Technology Assessment Center is going to lead the strategies for developing health technology assessments and appraisals in different health sectors, whether it's in the private or in the public sector. We've been using health technology assessment as a tool for several years, and with this we have already evaluated multiple molecules, new molecules, including gene therapy and also cell therapy and other biologicals before they were registered in Saudi Arabia, so that once it's registered and we have an official pricing for it, it goes through the tendering process, the national tendering process. We already have our assessment ready, and then we could conduct our budget impact analysis to see the affordability, for example, and also conduct our own economic evaluations. Two of the most important things that we worked on over the last 2 years. Well, first one is development for the first time the utility evaluation set for Saudi Arabia for the first time using the EuroQL 5D 5L approach, and we are actually publishing our findings in 2 months' time from now. And this is going to be useful, very important for everybody, including economists, researchers, decision makers when it comes to valuation of the quality of life of these technologies in terms of quality of life. The second thing that we also completed last year was, for the first time, we have published our cost-effectiveness threshold in Saudi Arabia, which is going to be very important to assess the cost-effectiveness of these technologies, and it's going to be focused mainly on the chronic diseases and other general medications, not the specialty medications or end-of-life technologies. The last thing that we're working on is we are developing our multi-criteria decision analysis, or MCDA, currently for evaluating these innovations, especially when it comes to small population, very expensive medicines, where justification for the use of these medications might be very difficult by decision makers.
Thank you. I'll move to Professor May Farid. How do you ensure that there is a maximum value actually ensured, or how can we ensure that the maximum value could be generated from the expenditure already made? I know there is always a challenge between how to balance between equity and affordability, but how can you ensure that it will be a benefit, or it will be the maximum value already from the expenditure made?
Well, thank you. Let me first first tell you something. I want to go back one step, and then I will come to this.
Sure.
Let me start with different channels. We try to accommodate the implementation of the system in order to maintain some sort of innovation and to make sure that this innovation will support the sustainability of the system on the long run. So we adopted many channels. One of them was to have some innovation in the diversified resources to the system itself, and how they can, we have a mix between contributory and non-contributory system, and how this can sustain it in the future without depending much on the treasury from the government. And also we try to look at the strategic purchasing side, and we tackled the three main questions: what, from whom, and how we're going to buy them. And while answering these three questions, we were focusing on your question now of how to assure the maximum benefit while doing this kind of balance between the expenditure and the resources that are available for the system.
Yes.
So through the strategic purchasing, when we looked at the what to buy, we had to look for the health technology assessment and to see the latest innovation in the services that could be provided. We had many activities with the Ministry of Health and Population, with the UPA on such matters to make sure that we are using or capturing most of the latest technologies and services needed for the population. On the whom to buy from, we already having, of course, HTA with us as our prime contractor for the time being. However, key factor or key player in the system is the private sector. And we already contracted 50 private sector providers, and we are at 50 private providers, and we are aiming to increase their expand their existence within the system, and this would do some sort of balance as well. And here we try to look at the pricing and to make sure that it's a fair price that would be appealing for both private and public sector. And then we go to the third question of how we're going to buy this, and we tried to accommodate the Egyptian context within having different or a blend of different payment mechanisms. We have the capitation and fee-for-service, and we also have the case-based for surgical cases. And this kind of blend, we try to assess after a while whether this is assuring the best model, not only for the payer but also for the providers, and if this is having the most efficient results that we're looking for or not. Each of them is having its challenges on ground, and it needs some sort of fine-tuning, I would say, as we go. But by the end of the day, that's how we are trying to make sure that there's some sort of monitoring to the expenditure from one side. And of course, as I start my talk, looking at the revenue side as well, and making sure that you're having enough revenue resources diversified enough to maintain the sustainability of the system is very crucial to us.
Thank you. Professor Mohammed Raed, I think that any healthcare system should focus on maximization of the outcomes. What are the recent steps taken in the Egyptian Health Authority to ensure that there will be an efficient healthcare services provision?
Firstly, I would like to thank Professor Haba for this meeting, the first Arab Health Economics, a great idea in Egypt. And I thank you for the organizing and moderating this session. Dr. Amir Al-Tilwani, our CEO in HTA, sending apologies. He has a sudden commitment today morning. I'm instead of him today. I would like to thank you to be with the elite here of the healthcare professionals in our session. Back to your question. The first step, I think it's the belief. We all believe in the project, we all believe in the dream to make Egypt provide a universal health insurance system. This was a dream. All the HTA colleagues believe that the project will be maintained by our efforts. The belief to be patient-centered care is the belief we are targeting to do it. So the first step, I think, is the belief. Second step is planning and studying. We didn't lift anything for the coincidence. During our planning to the healthcare facilities, projects and management, we are planning to maintain the main pillars, infrastructure, equipments, manpower, by doing some steps. First step, infrastructure and equipments. You know that the physicians and the medical staff need always a good environment to work in. If they work in a good environment, they can go to the maximum of their efforts. Secondly, is the patient. The patient, if you go to a clean place and be met with a consultant and specialist in different specialties, this will make him trust the system. The trust between the patient and the physicians and the nurses is a very crucial cornerstone point. We started here, as the Professor Hussam told us a few minutes ago, that the healthcare system in Egypt nowadays is 3 levels: primary health care, secondary health care level, and tertiary health care. This system provides the best utilization of the resources. The primary health care facilities gives a lot of scope of service in it to avoid the abuse of the utilization in the hospitals, secondary and tertiary hospitals. So primary health care got a great care from us, family physicians in the primary health care, well trained. Usually we make training sessions for them and training and education, continuous medical education for them, how to manage the patients, when to refer, especially this point is very crucial, when to refer the patient to a hospital. Because at this point, if we refer the patient to the hospital in the right time, it's very good for the patient, very good to our resources, not to abuse it in the primary or secondary healthcare levels. Third step, digital transformation. Digital transformation and technology. We insisted, you know that all the medical staff is always resistant for technology. They want to go to the clinic and do the operations and finally go home. But we insisted to the medical recording system and all the facilities in HTA to be digitally transformed. Our medical records almost now in most of our facilities is electronic medical records. This make time and effort much less, even with the resistance, but we create a culture of changing the mindset of our teams, our employees in the facilities to cope with the new challenges in the healthcare system. Our healthcare system is going on, and we need all the participants and the stakeholders in our facilities to go with us. So digital transformation is now one of the great challenges, but we succeeded in, I think, 50 to 60% of our facilities totally transformed now. And we are going to complete them to 100%. The creativity of the clinical governance is the fourth step. Clinical governance is one of the most important. Me, myself, at the first, when we talk in our facilities about the clinical governance, I thought that it's just an expression. But when we implemented the clinical governance in our facilities, we found that the value of flour, Professor Garrison showed us in his presentation, clinical governance, almost all the pillars in the value of flour is found in the clinical governance. The clinical effectiveness, we put a criteria for the physician or the nurse, the medical staff in general, will work in our facilities, revising the credentials, revising the clinical privileges. Not a physician just working in HTA, but we have to know the credentials and the clinical privilege of him. This was the first thing. Clinical effectiveness comes from this, comes from knowing the standards and the guidelines. When we stick to the standards and the guidelines, and we put the benchmark in front of us all the time, we found that a lot of improving in our outcomes. The mortality rate decreased a lot after clinical governance implemented in our facilities. The morbidity rate in our facilities decreased a lot last year. We implemented this and we made trainings for all the second line managers in EHA and in the hospitals and primary health care centers. First training course, I remember that it was 5 only attendees. The last one, last month, above 100. All of us, lessons learned from the clinical governance is a lot. We have great variance in the numbers of the KPIs we put in the facilities, improving a lot in the KPIs, key performance indicators in our facilities, improved a lot of the clinical governance. The clinical audit in our facilities make a difference also. All the pillars of clinical governance, especially the last one, not to make the conversation too long, patient involvement. You know that abroad, patient involvement and public involvement in the plan of care of our patients is very important. The patient had to know, has the right to know the plan of care. His relatives has to know the plan of care, especially in our country. You know that the medical errors and also abroad, medical errors is one of the leading causes of death in the facilities, the medical facilities. So by knowing the guidelines and the standards for the physicians and nursing staff and the plan of care for the patients, this put us in a good position. You know that the project is 3 years old now, but we're improving a year after year, implementing the steps of clinical governance and, as I told you, the planning and studying well the healthcare gives us a good image in front of all that the EHA is providing a good healthcare service. I think this is a summary for the steps.
Thank you. Thank you. I believe that we all have the same vision, or one vision, is to support innovation. Innovation contributes actually to 60% of global disease burden reduction. So I think it's very important to invest in innovation. It's very important to invest in science, math, technology, because actually innovation relies on science, math, and technology. So I will try to conclude at the end. I think that without innovation, there will be no future. There will be no better outcomes, no better health. Now, health is a prerequisite for any education, for any economic development. Thank you for paying attention, and thank you for the panelists for sharing experiences and discussions. And we'll move to the next session. Thank you. دكتورة هبة نصار. Dr. Lamis Ragab. Dr. Lamis Ragab is the co-chair of this session, and she is the vice president for New Giza University. Dr. Sarah Adlal, she is the president of Emirates Health Economic Society, and she is with us online. So you have her, please. Dr. Shehan, can you just make sure that Dr. Sarah is with us? Dr. Mehdi Corollos, head of Central Department of Health Technology Assessment, and Dr. Amgad Talat, General Manager, Specialty Care Division, Eva Farm. And Dr. Hajar, I know that you have a plane, so I want to welcome to Dr. Hajar Abdulhaim, Director of Drug Policy and Registration, Ministry of Health, Saudi Arabia. Dr. Sharif Askar, Ahlan, Dr. Sharif Askar. Eva Farm? Yes? Eva Farm, yes. Okay. This session is our economic reform and equity countries' experiences. So we are glad to have two countries with us, two representatives of very important countries with us. And when we talk about reform and when we talk about efficiency, then we have a trade-off between both of them and equity. According to WHO, equity in health is the absence of avoidable, unfair, and irredeemable differences among various groups. Health equity implies that ideally everyone should have a fair opportunity to attain the full health potential and that no one should be disadvantaged from achieving the potential. As I know that Dr. Hajar will have a plane, so can I start by addressing Dr. Hajar the first question, and Dr. Lamis can. I think health equity implies that ideally everyone should have a fair opportunity to attain their full health potential. How can this be achieved, and if you can give us your experience?
Thank you so much. I would love to share one of our examples in the Ministry of Health, having one of the national program called SMA program, which we carry at the Ministry of Health, and we cover these three medications in the management of SMA for the entire Saudi Arabia hospitals. And we have a clear path whether for the approval of these centers and criteria for patients to make sure that every request we receive, there is certain criteria to evaluate. So every patient will have a fair evaluation, a process, and for him to assign or her to assign this medication or the complete, let's say, services when it comes to patients with SMA. So I think this is one of the programs that we carry in the Ministry of Saudi Arabia now. It has been completed like more than 5 years, and we're still continuing it. Because of this success of this program, other programs is being studied at the Ministry of Health to follow the same program or setup of this program.
Mm-hmm. That's interesting.
Thank you.
Well, I carry on with you, Dr. Hajib, because you have a plane to catch, and this will give you the to stay a little bit. Or I thought she was moving, so we'll ask you all the questions at once. Sorry, to let you free. For sure, there is a difference between health reform policies in advanced economies and emerging economies. One of the questions is how to move towards public coverage and at the same time not undermine sustainability. And the second question is how to overcome the challenge of the limited resources and the lack of health indicators or substantial lack of health indicators towards establishing equity.
Thank you so much. So I'll start answering the second question. So for us to accelerate, let's say, the access of these new innovative medications with very high price tags, we tend to have different innovative contracts with the pharma industry. Understanding the population, understanding what subset of patients that would be eligible for such medication. Plus, we intended to have a large registries that it's not a regular registry, but it's more of linking the outcomes to these medications at a certain time point. And whenever we have definitely a definition of patients' failure or responders, and then certain, let's say, agreement with the pharma, what is the percentage of rebate of this, in order for us to shoulder the cost with the pharma, accelerate the access of these medications, and ensure the outcomes that we are getting. So we have done this for the last 3 years, and we have added more than 16 new medications and innovative medications, let's say, to the formulary. And this is exactly, we tend to share or evaluate our formulary and switching, let's say, as we talked last night on the what actions that we did, switching to biosimilars. Now in the Ministry of Health, all our medications that if we have a biologic and there is a new or registered biosimilars, all our biologics being switched to biosimilars, and this really had a major impact for us to open the door for a new innovative for us medication to be entered to our formulary. So this is just, let's say, a summary of how we can ensure or accelerate the access of these medications. Now for the coverage, I think this is something to do with the plans of the insurance companies and having the, we have the a formulary now. It's been released for this insurance and having different tiers and making sure that every let's say medications that's been there categorized in tiers based on the plans that's been registered or approved upon it. Thank you.
Dr. Mary, at the Unified Health Purchase Unit or Authority, how could you achieve this issue of equality and equity? I mean, is there? I know you are at the head of the health technology assessment, but have you addressed this issue in your authority?
Yes, we already faced some challenges to achieve equity in our authority. Most of them because of lack of data not only lack of data, but in some cases the quality of data itself. And sometimes we have data, but it's not of the high quality. Also, we face some issue about quality, as we have a challenge because of the fragmentation of our health system. So we didn't have one unified treatment protocol for each disease area all over Egypt. So each authority has its own treatment protocol that make us suffer a lot to collect data from each other. Also, we have a challenge in that we didn't have digital patient record, so we can't retrieve data about patients. We suffer from publication also. We didn't have enough publication in Egypt and also in all the region as well. In some disease area, we have patient voice to make assure that the patient is in our centric point. But in some disease area, we didn't have, so there is not equity for all patients in all time. This is what we already have challenges in our beginning time.
We are really pleased to have with us Dr. Sarah Dallal, the president of the Emirates Health Economic Society online. Welcome, Dr. Sarah.
Thank you so much.
And we would like to ask her a question about, do you think that there is really a difference in health reform policies between advanced economies and emerging economies, and what are the main aspects of these changes, and at the same time, if there is any difference, how to face the challenge of substantial lags in health indicators and limited resources towards providing equity in emerging economies?
Thank you for the question. The difference between advanced economies and emerging economies definitely is the flow of money, and the focus and the vision that has been put onto health may be different in different economies. Even in advanced economies, if we're taking it as a big blanket, some advanced economies may not be preferring health as one of their top agenda items versus other emerging economies. So sometimes we cannot put them in the same buckets. One of those examples is the United States of America, where this expenditure on health is accounting for more than 18% of the total GDP. But whereas in other countries where they're probably OECD countries, where they might be, we can categorize them as less advanced or maybe not into the emerging markets, they would be having a lower GDP expenditure on health with the better healthcare outcomes. So sometimes even the vision itself may differ. The way that we also handle the healthcare system, it all goes back to the clinical governance and the leadership. But if to be said that the flow of money can guarantee access, that is not mutually exclusive. Flow of money does not be, maybe it can reach to a certain level of achieving certain access, but it may not be equitable. And this is where we try to figure out how we can tackle the universal health coverage as being one of the pillars of getting healthcare at least to a sort of extent, or to an instant of having equitable healthcare to everyone. Now, again, also with tackling that universal